Good evening, everyone. I am Arpita, representing the IJCP Group, a legacy medical communications organization established in 1990 by the late Padma Shri awardee Dr. K. Agarwal sir. We are honored to welcome you all to today's insightful webinar on IBS symptom analysis and treatment decoded. Now, IBS continues to be a challenging and often misunderstood condition impacting millions of lives. We are truly privileged to have with us Dr. Anurag Govil sir, who is HOD and Senior Consultant of Gastroenterology at STM Hospital, Jaipur, a distinguished expert with extensive clinical and academic experience in GI disorders. Sir will be sharing his deep insight into the diagnosis, symptom, differentiation, and management strategies that can enhance patient outcomes in IBS. We are looking forward to this very engaging session, and without doing further ado, I would now request sir to please start with the topic. Over to you, sir.
Yeah, thank you so much. Can you hear me?
Yes, sir.
Am I
Audible.
audible?
Yes, clearly.
So thank you so much. It's a privilege to be a part of these sessions that IGCP holds, and I would really thank you for considering me to be one of the faculty to take a lecture. Now, the topic for today, as you can see, is irritable bowel syndrome, and not a very engaging topic, but the topic which has been designed, the symptom analysis and treatment decoded, that sounds interesting. And it took me some time to decide, what I should be talking about when it comes to symptom analysis and treatment decoded. So let's see if I can do justice to this topic in the next half an hour. And we might take up a few questions after that. So irritable bowel syndrome, as you all know, it of course encompasses a plethora of symptoms. It's a symptom complex, and there are no real diagnostic markers. So what you have to fall back upon is your own clinical experience and expertise. What needs to be understood is that it is a positive diagnosis. It is not a diagnosis of exclusion. It is not that you do a set of 100 tests, and because all tests are negative, and that is why it is irritable bowel. No, it's not like that. You have a very typical symptom complex. We will take up each of these symptoms. And having said that, if it fits well into the criteria, which will also come up, it becomes a positive diagnosis and definitely not a diagnosis of exclusion. Rampant is the word. 10 to 20% of the world population experiences irritable bowel. India, luckily, is slightly on the lower side, up to 8%. Only 10 to 20% seek medical care because it's basically symptoms. It doesn't pull you down that real bad. So they don't reach and seek medical care. But what is, I would say, encouraging for at least me as a gastroenterologist is that most reach out to the primary care physician, and only some, which is 20%, reach the gastroenterologist. Now, that's the criteria. This is about almost 7-8 years old now. Maybe next year we're expecting Rome 5 criteria. What they did in this criteria for diagnosing IBS was they took away abdominal distension. The gaseous distension is a part of the criteria. And so it's all about recurrent abdominal pain. It's usually 1 day per week is what they say the frequency is, but I personally don't really concentrate too much on the frequency. It is the pain which is related to the defecation. So abdominal pain followed by defecation, or abdominal pain followed by a change in stool frequency, or abdominal pain associated with a change in form of stool. Now that's what it is all about. And if the symptom frequency matches what they say, which means about for 3 months in the last 6 months, we are reasonably certain that it's IBS. So the most consistent clinical feature in IBS is altered bowel habit. If it is predominantly constipation, it is called IBS-C. You all know it, but I'm repeating it for making it reasonably clear as what I'm going to talk about. If it is diarrhea predominant, it's called IBS-D. If the two alternate, which are also not very infrequent, it is IBS-M. And there are certain situations where No matter how hard you try, it's difficult to classify them into one of these two, and it's called IBS-Q. These bowel patterns, and why it's difficult at times to classify, is these bowel patterns are highly unstable. 75% change subtypes, within their years to that they visit the doctors, and a phenomenal amount of 30% change from either IBS-C to IBS-D or from IBS-D to IBS-C, whatever it might be, just within a span of 1 year. So these symptoms keep altering. One, it is an altered bowel habit, and that also keeps altering. Now, let's take the first symptom, constipation. We'll spend some time here, Understanding symptoms is part of the discussion today. Now, constipation could mean, different things to different people. I mean, to us physicians, most physicians think that if there is no stool frequency is less than 3 times a week, then that's constipation. But not necessarily that the patients also take it that way. Let's say the patient's perspective. So if they have to strain excessively, that's constipation. And why it is important to ascertain what's going on is because the medicine changes accordingly. All of these symptoms, which of course all relate to constipation, does not boil down to a single tablet or the same medicine. So if there's excessive straining, then probably what you need is to give a promotility, something to make the intestine move faster. If it is hard, lumpy stool, which also has constipation to the patient, there you need a stool softener. If it is incomplete evacuation, so the patient could actually be going for stools multiple times, but because they feel it is incomplete evacuation, they call it constipation. So in true sense, it is more number of stools amounting to diarrhea, but they interpret it as evacuation. And now if we start treating it with excessive straining or hard lumpy stools, the way we are doing it, either with stool softeners or promotility, we might go wrong. So incomplete evacuation probably needs antispasmodics, The sense of obstruction has to go. There could be no stool at all. Now, no stool at all would probably need a combination of the first two, which is a promotility and stool softener. So what I'm driving at is one has to really spend time on trying to understand what the constipation means, which tells you exactly what medicine one should be using. Gas bloat also is taken as constipation by a lot of patients. That probably is because there is about a 25% overlap between dyspepsia and irritable bowel. So 25% of irritable bowel patients also have dyspepsia and complain of gas bloat. It obviously is not because of constipation, but they definitely relate to it very strongly. Varying consistency over the same day is also another feature. So they come up with a lot of straining and very hard stool in the morning. Over the day, what happens is the stool becomes normal. At the end of the day, they say they have stools which is loose. Now that's also constipation. One could call it diarrhea too. And these patients are really difficult to treat. I mean, giving them less medicines is the best way to go about it. So constipation really needs to be defined what it means to the patient. Diarrhea is the second most common symptom. That's not so much of confusion around this area. These are small stools, these are loose stools. But overall, the volume is definitely not more than about 200 cc's a day. These episodes are surely aggravated by emotional stress. There is a definite component of increased gastrocolic reflex, so that the patient says that every time I eat food, I go and pass motion. And so that also to them amounts to diarrhea. A lot of mucus. Now, mucus is just basically a feature of irritability of the colon. And as the name indicates, it's irritable bowel. So yes, there is a lot of mucus with stools, which normally can also be there and should not always be taken as pathological. But what is certain is that these patients with diarrhea, one, do not have any malabsorption. So no vitamin deficiency. They don't lose weight. They sleep well at night, and there is no blood. So much so for diarrhea. And sorry, we've done this. Then we come to IBSM, where, like I said, that it could be, phases of weeks to months of constipation followed by diarrhea, or vice versa. or within the same day, the patient could have varying consistency stool and varying frequency. IBS-U, of course, detailed history, lot of time spent, you still don't know what's going on. Having taken this history the way we would want it to, investigations, rather than set pattern, one has to individualize to every single patient based on their predominant symptom. Same set does not apply to all. And of course, we don't have to be Sherlock Holmes. We can't be micro analyzing these symptoms and micro investigating them. We have to be sympathetic and soft even when it comes to investigating these patients. So some basic set, of course, should always be done. A basic biochemistry, a CRP, I would say. It's good to rule out celiac disease, which is wheat allergy, by doing a tissue transglutaminase. Thyroid is very important, yes. A routine stool for parasites. Lately, a lot of patients, a lot of doctors, including us, are using calprotectin, to differentiate between inflammatory bowel disease and irritable bowel disease, and it is helpful, yes. So if there is confusion, the stool calprotectin also can feature as a primary test for the patient suspected of having IBS. Sigmoidoscopy and X-ray abdomen, both useful but optional. But one needs to remember, and which I'm sure everyone knows, and it's there in every single textbook, every single talk that you hear, red flags. So what you need to be aware and you have to be actively looking for. So if there is anemia, if there is fever, a diarrhea which is persistent, just not going, rectal bleeding, very severe constipation, no stool for days together, weight loss, patient gets up in the night to pass stools, or because of pain, the patient gets up in the night. There's a family history of GI cancer or inflammatory bowel disease. Or even if there's new onset of symptoms, 50 years plus of age, these are the red flags. That is where you need to be Sherlock Holmes. You have to analyze them well, investigate them well, and reach a good pathological diagnosis. Having done that, we will discuss in very brief the management. I will be talking about the various classes of drugs here. Will not be going into every single drug. We'll be talking about drugs which are available in India only. And then finally, we'll try and sum it up as what all can be used based on the symptomatology. So my own clinical experience suggests that when it comes to management, the first thing is when you're taking the history, you have to accept the patient's symptoms and his distress, his or her, as real. If we pass them off and tell them that this is excessive worrying and unnecessary somatization, it's not going to work. Agreed that a lot of these irritable bowel patients have significant functional overlay. They are stressed, they're prone to anxiety, they're depressed, but you can't be telling them all in the first go. You have to accept the symptoms as real, give a very sympathetic hearing, and it does the job. Patient hearing is the key to treatment. In fact, it has been studied, that if the history is taken well, and if the physician continuously listens to the patient without interrupting for about 2 minutes, it works extremely well. The patient satisfaction rate goes very high, and they become receptive then to what the physician says. So good history, a lot of time spent. This is almost like a repetition, but why I'm doing it is very important. So your approach should include acknowledge the symptoms, educate the patient about the disease, reassure them, and it will definitely improve the treatment outcome. I must mention here that a very senior gastroenterologist in our city, which is Jaipur, he is known to handle these patients very well. And this slide comes from him. He spends time with these patients. He acknowledges the problem and educates them. In fact, goes to the extent of making diagrams, to explain what's going on, what's the psychological overlay and what's motility and so on and so forth. So he spends time with his patients and does it really well. So having heard the patient, you have two possibilities. One is to just go for a non-pharmacological approach. Or if it doesn't work, obviously drugs are there. So there are drugs for constipation, there are drugs for diarrhea. Spasm and pain is a feature, so antispasmodics will obviously be there. A lot of attention to probiotics everywhere, not in just IBS, every single GI disorder you talk of probiotics. So a lot of attention on probiotics, antibiotics, of course. And last of all, which is definitely not the least, is the modulation of the gut brain axis, because there is a functional overlay for sure in most patients, I would say. So, what is non pharmacological approach? Non pharmacological approach. So, you need to educate the patient about the importance of exercise. Now, how does this exercise help? Exercise is known to help predominantly the IBS-C, the constipated patients. So one has to, even brisk walk is just enough. You tone up the abdominal muscles, it helps intestinal movement. And what has also been studied is it might not happen in just 1 month or 1 year. Even up to 4 years of regular exercise might be less, or you can say enough, to bring the desired result. So if you get exhausted early, the desired effect of exercise does not happen. It is important, and it is very important. Toilet training. Yes, we heard about toilet training for children, for neonates, but here are adults who need to know what and how they need to handle their own toilet habits. Now, I just skip to the next slide before we take up diet. Now, this is what toilet training is all about. Most important is posture. So if they're constipated and they're using the regular English style pots, then that posture is not, the most physiological posture. The Indian loos earlier were the most physiological. And why I say that is that the first diagram, if you can see, cartoon that you can see, the patient is sitting on an English pot, and the last one, the lower one in the same row, that's the sling, which creates an angle in this posture between the sigmoid and rectum, the recto-sigmoid junction. This is not physiological. The rectum is not straight, and therefore they tend to remain constipated. However, if they raise their limb and try and achieve the Indian squatting position as far as possible, the sling relaxes, the rectum straightens, and that eases constipation. So posture needs to be discussed, needs to be told, and needs to be practiced. Straining. Most patients tend to strain a lot. They fight to get the stool every time, every single day. They've been taught by their parents that stool has to happen in the morning. Well, not necessarily. If you have to really strain real bad, then maybe after a few days you'll get rectal prolapse, but you will not get stool. So excessive straining is bad. If it doesn't happen today, it's going to happen tomorrow. We'll give drugs, but excessive straining has to be avoided. And that's part of toilet training. Sitting there on the pot for hours together, not because of a mobile phone, but because there is no stool, is wrong. You need to spend little time. It could be 5 minutes for someone, 15 minutes for someone, but surely not, hours together. And sitting and straining and spending a lot of time does not help. It just, creates a conscious effort on your own part to be very perceptive of the symptoms that you have, and that creates stress. So spend less time, strain less. Doesn't matter if this stool doesn't happen today. Use the right posture. It's going to happen tomorrow. Diet. Now, I'm sure each one of you knows that the patients are very finicky when it comes to diet, especially the irritable bowel patients. They keep relating every single symptom of theirs to the diet that they take. So the traditional dietary advice works, which means they should have regular meals, reduce caffeine and alcohol, stop irritating your intestines, good hydration helps in constipation, and sugar restriction, because that decreases gaseous production also. So this simple dietary advice helps. For diarrhea, you can tell them, not to have those carbonated preserved drinks which contain a lot of sorbitol and mannitol, which leads to diarrhea at times. For gas, one can restrict gas producing legumes, and which is beans and peas, and also lentils at times, So, rajma, chana, these are things which some patients don't agree well with, and they get a lot of gas production, physiological gas production because of that. So, it could well be avoided. For constipation, of course, you need to increase fiber, especially soluble fiber like isabgol. If you take insoluble fiber like bran, it can might give you more problems, more constipation and more gas. But soluble fiber like isabgol is good. It increases short chain fatty acids, which is healthy for the intestine. And in fact, it's a nutrient for the intestine. And also, this fiber interacts with smooth muscles and enteric nervous system, increases the transit, which means the transit time is increased, but the transit is increased, and so helps in constipation. So these basic dietary measures go a long way. Well, very popular is the FODMAP diet. Now, what is FODMAP? There are short chain carbohydrates in your diet which are not absorbed well, which are poorly digested, and they create distension. Some examples are like if you talk about vegetables, then it's broccoli and cabbage. If you talk of fruits, apples and peaches, these carbonated drinks that we discussed about, wheat and corn, which have a high glycemic index and can form a lot of gas, and some others like nuts and lentils, which we already discussed. So these fermentable oligodiemonosaccharides and polyols, if they're there in your diet in high content, then it can give rise to some symptoms. And avoiding FODMAP diet, it has been studied extensively, a meta-analysis of 13 RCTs, over close to 1,000 patients. It ranked first for all endpoints, which means all symptoms of it to all patients among the dietary regimes. But what has not been studied is when you initiate this diet, what do you do to reintroduce them? You can't be stopping them for life. So subsequent reintroduction has not been studied that well, but surely there's a lot of promise in low FODMAP diet. Gluten-free, patients do it themselves. Some doctors also ask them to do so, but there is no basis to meta-analysis, no significant difference in the symptomatology, cannot be advocated as of now. Mediterranean diet, which is more of poultry and fish with the healthy vegetarian diet, also helps, has shown some promise, but it has not been that extensively studied. So coming to diet, I mean, maybe a low FODMAP diet if the regular dietary regime doesn't help, but for most, it should be just a regular dietary advice. What do we have on cards when it comes to treating constipation? So we have fiber, we have osmotic laxatives, we have stimulant cathartics, and we have secretagogues like linaclotide and lubiprostone, which have recently been made available in India. We'll take them, each of them in very short, because constipation is a predominant symptom, and I'll just spend the next 2-3 minutes on constipation. So fiber, you add fiber. What is important is a lot of water. You have to have plenty of water with isabgol to make it work. It acts like a gut regulator, which we already discussed. So it increases the bulk of stool, the contractile force increases, the propulsion increases. 2 teaspoons, 1 teaspoon will be 5 grams. So 10 grams morning, 10 grams evening is the right dose. Meta-analysis, a lot of RCTs, a lot of patients. Again, 1,000 plus patients, 14 RCTs. All global IBS symptoms improve with high fiber. Again, a lot of promise here. But it is not useful, one needs to remember, with patients who are really badly constipated. Don't pass stools every day. They might worsen with isabgol, especially if water is not taken. The stool will become harder, they will get bloating, and they might get pain also. So there could be worsening of constipation. So fiber should be introduced slow, step up the dose gradually, ask them to take a lot of water. PEG, which is polyethylene glycol, also used these days very extensively. It's a high molecular weight polymer, causes diarrhea because of the osmotic nature. So increases the frequency of stool consistency gets better, laxative consumption goes down. Dropouts from this trial that we're talking about in GUT 2000 decreased when PEG was used, but it doesn't improve pain. How does one use PEG? Now, this is not a copybook presentation. This is one very practical way of using it. So patients who got fecal and severe constipation, we can do disimpaction with PEG. One sachet is about 70.5 grams. One sachet needs to be dissolved in 250 to 300 ml of water. Keep taking every 15 minutes one sachet till there is diarrhea. The same can be repeated in the next coming few days. Gradually, the dose keeps going down. It improves global symptoms, works very well for patients with severe constipation. But remember, because we induce diarrhea, there could be weakness, fatigue, and very occasionally electrolyte imbalance. Osmotic laxatives like lactulose and lactitol, again, use very extensively osmotic laxatives that they are work by increasing the fluid content in the stool, and stimulant cathartics like Dulcolex and Cremalex and the seed of sodium picosulfate, which is Cremalex, extensively used, but we, at least as gastroenterologists, are not very keen on using them because it can cause cramping. Gradually, there is definitely tachyphylaxis. The effect goes, and it can harm the enteric nervous system. Misuse of these stimulants, cathartics, can lead to cathartic colon and a colon which just doesn't move after a few years, which is not good. Secretagogues are the ones which increase the fluid content in the stool, like linaclotide and pleclinotide, which are recently made available. There, I will not go into details. Gonaride cyclase agonist, and it accelerates the GI transit and increases the secretion of fluid and sodium bicarbonate also in the stool. It significantly improved pain because there was passage of stool. Diarrhea is a side effect, but basically these drugs are right there, available in India, can be used for constipation, especially if the stool is hard. Another secretagogue is lubiprostone, again very widely used. It works on the chloride channels, has the same effect like the previous one, well tolerated. The side effects again are diarrhea. But overall, all of these have almost a similar efficacy, and they're surely superior to placebo. IBS-D, which is diarrhea, is a single slide that are there because diarrhea is easier to handle than constipation. So the first one, which is the opioid receptor agonist, loperamide, everyone knows about it, very extensively used, proven benefit in RCTs, and it's called the first line drug. I personally don't use it very often because it can give rise to real bad constipation. And then, you're treating diarrhea, then you start treating constipation, this alternate things keep happening. So I tend to use something which is less strong, I would say. Allodonin is not available, so I don't think we need to discuss about it because of sphincterospasm. It was discontinued. Cholestyramine, which is a bile acid sequestrant, is supposedly the second line drug, but it is expensive. The taste is bad. The patient don't tolerate it well. So I don't use this also, which is a recommendation as a second line drug. So at least in my practice, the first line, which is loperamide, the second line, which is cholestyramine, is not used that often. What I use is 5-HT receptor antagonist, which is ondansetron or Zoffer, ramosetron or palositron. All three are available. Allosetron, of course, is not available because it was discontinued because of ischemic colitis. Excepting for palmocitron, the other two have been studied extensively in number of RCTs, patients running in thousands again. It is very useful and the effect can be reversed very fast. So I tend to use ondansetron and ramosetron for patients with IBS-D. It works really well. Antispasmodics, yes, because there is pain. It relaxes the smooth muscles. It decreases the contractility and therefore decreases the postprandial urgency and cramps. It should be taken 30 minutes before meals. Global improvement is what the antispasmodics give. So there is this meta-analysis with 22 placebo-controlled trials. That's extensive data. So pain, of course, goes down, stool frequency goes down, but the problem is the dry mouth, blurred vision, and fatigue. I'm rushing over because I'm already exceeding my time. These are the agents which are available as antispasmodics. Some are the centrally acting ones, which is the hyoscine, which is buscopan, clinidium, and dicyclomine. Also, there are lot of salts available which act peripherally on the colon itself, on the intestine. They act on the calcium channels there. So the examples, of course, are mebivarin, which is colospa, autolinium bromide, which we as doctors know as Menoctil, pinavarium bromide, known as LD-Set. I'm just giving one example of the trade names, not that I promote these trade names, but it's just to make you more familiar that these are available. and are extensively again used as antispasmodics in patients of IBS. Colofac, which is dotaverine. Peppermint oil also extensively studied, but the quality of evidence for peppermint oil is not very high, and so it is used less frequently. Of course, there are many combinations available, which is not the best way to go about it, of antispasmodics and anti-anxiety. Uh, this is one study. I will skip the study done by one of our professors in Jaipur, which is Dr. Rai. He used dotaverine for 4 weeks. Excellent results of dotaverine in patients with IBS with pain and constipation, and even pain with diarrhea. So American College of Gastroenterology also goes on to, recommend these antispasmodics that we've discussed as an important component of treatment for IBS patients. Well, we can modulate the gut flora in terms of probiotics, and I would just come to the meta-analysis, which is, like I said, probiotics extensively studied, more than 10,000 patients, and they demonstrated significant improvement in pain and bloating, no change in stool frequency or consistency, but the evidence for a particular species is not there. So if you were to use probiotics in your practice, then they largely use with patients with distension and maybe some diarrhea. Give it for about 3 months. If it helps, it can be continued longer. Otherwise, discontinue probiotics. Antibiotics means rifaximin, which is a gut-acting rifaximin, absorbed very poorly, and there is insufficient data to recommend the routine use of antibiotics, but still there are fairly large RCTs available which show that they are more efficacious than placebo, especially when they're used in patients with gaseous distension and diarrhea. Everyone knows, everyone's seen this movie, Motion Se Hi Emotion Hai. It is such a true depiction of what happens to patients with constipation and how much it can play with your emotions. So, if it really plays with the emotion, here are some drugs which modulate the gut brain axis. These drugs actually decrease the visceral hypersensitivity and decrease pain. They are antidepressants to make the patient feel more lively. Significant number of patients, 18 RCTs available, for both tricyclic antidepressants and SSRI. We will not go into details of each of these drugs, but again, they are used extensively, and also available in India are combinations which use antispasmodics and anti-anxiety antidepressant drugs in form of TCAs and SSRIs. Useful, yes, for sure. So to summarize, good patient history taking to identify the predominant symptom, educate and reassure them. You have to explain, name the condition, tell them it is irritable bowel, provide reassurance, then based on their symptom optimize the treatment. First consider the lifestyle modifications and dietary modifications. If they don't help, you need to shift to pharmacological drugs. And this some last slide, which is the summary of the pharmacology that we discussed. For diarrhea, you have loperamide and cholestyramine in the first and second, and yes, ondansetron, which I personally use more than loperamide or cholestyramine. For constipation, you have isabgol, lactulose, polyethylene glycol, lubiprostone, and linaclotide. All of them are available in India. All of them can be used. You just have to see what the patient wants, what the prime symptom is, and which one to use between these two. Smooth muscle relaxants for abdominal pain, yes, very useful again, especially in combination with tricyclic antidepressants or SSRIs. And they do take away the pain. And once the pain is gone, the nociception is gone, the visceral hypersensitivity is gone, the frequency of stool also goes down. For gas bloat, dietary modification, especially low FODMAP, probiotics, and maybe even antibiotics that we discussed in form of rifaximin. So if you do it well, the screams can turn to smiles. If you don't spend time, the scream remains screams. Thank you so much. I'm
Thank
sorry
you,
I
sir.
have exceeded my time.
No problem, sir. Thank you so much for the insightful talk. Now let us see what are the questions that have come from our audience. We'll take like
Can you
three
hear me?
questions from them. Yes, sir. Audible. You're audible.
If you can
Sir,
hear
am I
me, we can
audible?
take questions if there are any. If we are already running short of time, we can call it a day.
Sir, am I audible to you? Am I audible to you, sir? Sir, am I audible to you? Am I audible to you, sir? Hello, sir. Am I audible to you?
Can you hear me now?
Yes, I can hear you. Can you hear me?
Yes, I can hear you. I'm sorry if there is some disconnect. So if there is time for questions, we can take them. Otherwise, I'm sorry I exceeded the time.
No problem, sir. No problem. We'll take a one, two question and then we'll wrap up with the session. Sir, the first question is how do you approach the treatment of IBS with predominant psychological components such as stress or anxiety influence players?
I'm losing you.
So I have put the question. Can you see the question here?
Uh, yeah. How do you approach the? Uh, I can see it. It's interrupted. Psychological components such as stress and anxiety induce flares. Well, we discussed. I mean, this is a definite possibility. It's a very frequent happening, and these two class of drugs that we discuss, which is the tricyclic antidepressant SSRIs, they help in a long way, in a big way. So talking to these patients and explaining them, doing some psychotherapy yourself, and these drugs help. Hope I have answered your question. Is there any more question?
No, no, sir. We'll not take more questions. So we will call it a day.
Thank you so much. Thank you so much for giving me this opportunity. And again, sorry again for exceeding my time limit.
No problem. On behalf of the entire IGSP groups, I would like to extend our heartfelt thanks to you for your insightful presentation and thank you so much for valuable clinical takeaways for all the attendees. Thank you all, and thank you, and keep on attending the sessions.
Thank you.